Opinions expressed are those of the show hosts, not WSTU or Treasure Coast Broadcasters. Any reproduction or reuse of this program without the written consent of WSTU is strictly prohibited. Welcome to Paradox. If you'd like to join the conversation, call 772-220-WSTU. And now your hosts for Paradox, Dr. Ira Pearlstein and Dr. Leanne Talton.
And good morning, everyone. Good morning, Leanne.
Good morning, Dr. Ira.
And good morning, Frank.
Hey, good morning.
We're talking to Frank Mazapal, Chief Bottle Washer, Cook, and Chief Engineer.
He's taking out the garbage today.
Yeah, we walked in. He was taking out the garbage. We have a very special guest today.
Tell us about him.
Well, first of all, we owe him big. You know why?
Why?
Because this was a last-minute show. We had a guest cancel, and I had to get a guest. And I found a phenomenal guest, Dr. Rabih Kashouty, neurologist extraordinaire who practices right here on the Treasure Coast.
Welcome.
Thank you. Thank you for having me. Thank you, Dr. Pearlstein. I was getting ready for the hurricane, but you called me last minute. I dropped everything and I'm here.
Yeah, I dropped a shutter on my foot a couple years ago, and that was painful. I had to actually get a tetanus shot, but which I probably needed anyway. You know, we do have a storm coming, and I know we don't like to talk about the weather a lot. We're not meteorologists. This is kind of like the Academy Award week for meteorologists. This is their big thing. Guys, don't take this storm lightly. This may be a big storm. It may not. Nobody really knows the direction of where it's going. Those spaghetti models, there's European models, there's spaghetti models. For those of you that are gluten-free, I don't know if you can believe the spaghetti models or not.
No shortage on puns, just a shortage on water.
Right, just a shortage on water. And you don't have to buy bottled water. Did you know that, Dr. Kashouty?
No.
Yeah, people feel like they need to clear the shelves of bottled water, but you can take water and put it in coolers, and you can take your water and put it in thermoses. Couple hurricane tips I'd like to pass on this morning.
Sure.
Number one, never put gasoline in your house. Don't store your gas in the garage or in your home. Store it outside. Number two, if you have a generator, make sure it's well ventilated. The generator does not do well in the garage or anywhere near an open door because of carbon monoxide poisoning. That will kill you. Number three, use your washing machine as a cooler. You can fill your washing machine with ice, put your drinks in there, anything you need to keep cold. The lid will shut down. And then after the storm passes and you get your electricity back, you take out your food, you take out your drinks, and you hit the drain button on your washer, and all the water and ice go away.
Nice.
Next, fill your bathtubs with water, because if your toilets don't flush, you're going to need that. If you spill something, you've got bathtubs that are filled with water, and keep water in your sinks just to kind of wash up with. So those are some little hurricane tips that you might want. Prepare for the storm. Leanne, I was preparing for the storm. I went and got a new battery for my generator this morning. We're going to get people to come help me put up shutters at the house because it takes me like a full day to do it. But if I have a team, I can get it done in a couple hours. And I was thinking, perhaps a bad joke, but wouldn't it be cool if we had an ice cream store here in the Stewart area and we called it Hurricanes Ice Cream or just Dorian's Ice Cream? And we would have a special dish called the Cone of Uncertainty, and nobody would really know what they're getting. I don't know. Maybe not. Dr. Kashouty, how do you prepare for the storm?
I'm still new to Florida. It's very difficult to me to get along with hurricane season. You know, it's a very nervous time for me. But I just fixed my roof. It's a new roof, and bought a new generator. So I'm not leaving anywhere this time.
Right.
I'm staying put.
Now your kids, do they get anxious about the storm, or are they too young to know? Tell us about your kids.
Got two kids, 4 and 7. My 7-year-old, Aiden, he loves hurricanes for some reason.
He's got your
And
undivided attention. I'm convinced that's what it is. Like
it's,
you're at home and there's nothing to do other than watch them.
well, the last two hurricanes we went to Atlanta. So for him, when he heard this time that there's a hurricane, he goes, "Okay, let's start packing. Let's go to Atlanta." I said, "Well, not this time." He goes, "Why? We have to." Well, we're ready this time. This is my 4th year in Florida, so I should be ready.
And you're married.
I'm married to Dr. Yono, Noor Yono,
And what does she do?
a neurologist as well.
And you work together.
We work together, husband and wife. How lovely.
It is lovely.
Dueling neurologists.
I love it.
You don't hear that much.
So today the show is called Tremors-Shakes and Repairing the Body's Mistakes. And I'm really excited to have you here because I think neurology belongs in one of those categories where patients don't always know what a neurologist does. And anytime I'm sending my patients to a neurologist, I always say, this is half about you getting help and half about me getting help, right? Because neurologists help primary care doctors a lot of times, make decisions and give us suggestions for how to treat some of these conditions. So we're really excited to have you on the show.
I'm really excited to have him on. And it's one of those mystery specialties. They don't teach you a lot about neurology in medical school and residency, just like ophthalmology. We had an ophthalmologist on a few weeks ago, and now we have a neurologist on. So you're not only educating our audience, you're also educating us on who needs to see a neurologist sometimes and why they need to see one. So why did you choose the specialty of neurology?
It's a very interesting question. Going back to medical school, or actually even before medical school, in undergraduate school, I wanted to be a pediatrician. I always wanted to work with little kids, and that was my intention from the beginning. When I did my pediatric rotation, I couldn't handle it. It wasn't for me. As much as I love kids and treating kids, I just couldn't see myself being a pediatrician. Neurology was one specialty that I thought it would be best suited for me for multiple reasons. I think neurology is unique. There's a lot of advances when it comes to neurology, a lot of research, a lot of new medications, a lot of new treatments. And that's the interesting thing about neurology, that every year there's something new.
So can you tell the audience who may not have any familiarity with neurology what conditions you typically see during the day?
Neurology is very broad. So we see patients from headaches such as migraines or tension headaches to muscle diseases, nerve problems, as simple as carpal tunnel syndrome. My main training is muscle and nerve, and that was my fellowship training in Michigan. I see a lot of patients with myasthenia gravis, which is a muscle and nerve problem, a lot of muscle diseases, ALS patients, and other myopathies such as, could be different type of muscle disease. That's my background. However, other neurologists can also see epilepsy, seizures, could be also simple as dizziness, concussion. So those are the things that neurologists typically cover.
Mm-hmm.
So I would imagine there's a lot of overlap of what you do and what your wife does, but Dr. Yono, she sees more of the seizure patients and more of the Parkinson's patients, or how does that work for you? How do you decide in your practice who gets to see what?
So when we first decided to have the husband-wife team, so we decided that since my background is more muscle and nerve training, I focus on muscle testing such as EMG, electromyography, and nerve conduction studies, and medical Botox injection for multiple different diseases, such as dystonia, spasticity, cerebral palsy, excessive sweating or excessive drooling, abnormal head tilt. So those are the things I focus on. Other things that Dr. Yono focuses on are Parkinson, epilepsy, and also Alzheimer. That's main areas that she focuses on, and multiple sclerosis. Those are big areas that she covers. We just added a new epileptologist, Dr. Katani. She focuses mainly on epilepsy, but we all see general neurology. But we focus each one of us on certain areas in neurology.
So how do you do it? You've got 2 kids, you've got a busy practice, you're a neurologist, your wife's a neurologist. How do you do the time management thing? Have time for everything?
I watch a lot of soccer, by the way. That's something I try to fit in my schedule. It's difficult having kids, running a practice, and managing different things. Trying to have time for my kids, it's not easy. But I guess having good skills in terms of organization and scheduling, and good supporting cast around me. My manager is my brother-in-law. So he helps us a lot in terms of managing the practice and keeping things in place. And also speaking to the other doctors in town and making sure that patients are well taken care of.
Now you have 2 offices, correct?
So far, one will be open very soon in Tradition.
Okay, but you go to Port St. Lucie Hospital, the HCA Medical Center there,
Correct.
as well as the Cleveland Clinic hospitals.
Correct. We mainly cover St. Lucie Hospital for now. We cover the inpatient service and also the outpatient in Stewart.
When I was in my training eons ago, there were no CAT scans and MRI scans. So the neurologists were the nerdy guys. They would carry the multiple pins in different colors in their pockets, and they would draw out the nerve tracks. But it seems to me that the advent of CAT scanning in the 80s and MRI in the late 80s and 90s has really changed the way neurologists practice, because now you can see what you talked about. It's kind of like the early explorers.
Exactly.
They knew the world was round, but it wasn't until we actually
went up
we could see that it was actually round. So it must make your job perhaps a little bit easier.
Well, those neurologists that you're speaking about, did they wear a bow tie or?
They sure did.
And a pocket protector for all those pens.
Right.
Well, it's, as you said, CT scans and MRIs made the big change in neurology. And because of that, things have moved dramatically in faster pace when it comes to treatment and catching things early. I mean, we can go back. MRI was literally discovered in 1977, almost 1979, by an Armenian gentleman in New York. And he had the first patent for MRI, but it took 6 hours to do the first body scan. 6 hours just for a whole body scan. So since then, things have moved dramatically fast in terms of catching diseases early and managing patients.
So seeing a neurologist is no longer the kiss of death.
Not anymore, no. Unless you're seeing an old school neurologist, maybe.
Oh. So I want to launch into some neurologic diseases that you and your wife see. Can we talk about that for a little bit?
Absolutely.
Let's talk about Parkinson's disease.
Perfect.
And, I'm a movie buff. We always add a movie, talk about a movie that kind of adds to our discussion. There was a movie with Robert De Niro and Robin Williams that came out in 1990. And that movie was called Awakenings. And it detailed Robin Williams, who played Dr. Malcolm Sayer, Sayer, who in 1969 took these patients who were literally frozen. And these were the patients who couldn't move because they had depleted a chemical in their brain called dopamine, which helps with movement. And they believed, as was true, that the dopamine depletion was due to a viral illness that happened in 1918, 1919 during the great flu epidemic in this country. These people were literally frozen. And he administered to them L-Dopa or levodopa.
Correct.
And the more he gave them, the better they did, until it got to a critical point where they required so much that they developed a movement disorder from the increase in levodopa. Correct me if I'm wrong here. And let's talk about how Robin Williams helped Robert De Niro, brought tears to my eyes. Great movie if you haven't seen it. But that L-Dopa is now combined with carbidopa to kind of alleviate that. How do you know what to start someone on when they develop Parkinson's disease? And tell us a little bit about how you recognize Parkinson's disease.
That's a very interesting movie, and it has a lot of history behind it, really. From the 1960s, how carbidopa, or actually more levodopa, was discovered. So with Parkinson, the problem with the Parkinson is that you have death of neuronal cells in certain area in the brain, and those cells are responsible for dopamine. Dopamine is basically a very important part of our as a neurotransmitter to control our movements, and not just movements, maybe mood and other things. um, with To go back to Parkinson, symptoms don't start overnight. If someone comes into me with tremors and they say, oh, my tremors has been going on for about 6 months, but you really can trace back symptoms many years prior, maybe 10, 20, 30 years prior, people in their 30s and 40s. And that is astonishing, because by time symptoms start in Parkinson, you literally lost 70 to 80% of your neurons in your brain. You only have 20%, 30% left to keep forward and to protect those nerves.
Wow. If you just joined us, this is Paradox. I'm Dr. Ira Pearlstein, and I'm with my co-host, Dr. Leanne Talton, with our special guest today, Dr. Rabih Kashouty, neurologist here in Stuart, Florida. And you're welcome to call in if you have any questions right now about Parkinson's disease. Give us a call at 772-220-WSTU. That's 772-220-9788.
And Dr. Rabih, you're just telling us about Parkinson's and kind of how things progressed. But not all tremors are Parkinson's, correct? So I think that as a primary care doctor, we get the first line, people coming in with any kind of shaking and thinking, this is it, this is the end, I'm ready for this diagnosis. But that's not what you see, correct?
Correct. I agree with you. When I see a patient with tremors, we have to know the age. Are they young? Are they older? Medication is the first thing I look at. Certain medication can cause tremors. And you'll be surprised that by stopping those medication, whether it's for respiratory issues such as asthma, or for seizures such as Depakote can cause tremor, you switch the medication, then you notice that tremors are totally gone. Obviously, the history of alcohol use for chronic alcohol use can also cause some tremors and many other things. However, the history and the exams are as important. We have to see, are the tremors at rest? Are the tremors when you're holding something in your hand? With Parkinson, it's known that the tremors are at rest. With something else, it's called essential tremor. That's the good cousin of tremors, you can say.
Mm-hmm.
And those tremors are typically seen when you're doing something with your hands, when you're holding something, when you're drinking something, whether you're having a cup of water, or holding, drinking soup, with a spoon. So the exam is very important. And whatever we see on the exam with the history, we make the final diagnosis saying this is most likely Parkinson, or this could be essential tremor, or something different.
So that's like the Katharine Hepburn tremor. She didn't have Parkinson's disease. She just had a severe form of an essential tremor, or a tremor of aging.
Yeah, essential tremor is treatable, and there are many medications we can try, and most patients respond beautifully to it. And one of them is medical marijuana, if patients don't respond to typical medications.
I can't wait to talk about that later on in the show.
Me too.
We look forward to that. Everyone likes Michael J. Fox, great actor, Back to the Future, who unfortunately came down with Parkinson's disease. And people wanted to know, why did he have Parkinson's disease? And was it drug related, or was he just unfortunate and developed depletion of the dopamine substance in that part of the brain, the basal ganglia, or I think it's a substantia nigra, which is Latin for black substance, because dopamine kind of appears as a darker black color on scanning. But my understanding of Parkinson's disease, that there was a designer drug which actually came out in the 1940s, but it gained some popularity in the 1980s, and it was called MPT. MPTP.
Yes.
And MPTP was used to cut other drugs. And MPTP is metabolized to an active drug called MPPP plus. I don't want to
Yes.
get really complicated here, but the bottom line is that substance, that MPPP, rapidly depletes dopamine stores, and you can develop Parkinson's symptoms in as few as 72 hours after
Correct.
ingesting that drug.
I agree.
How
yes.
has that helped us understand the disease process better and led to better treatments for Parkinson's disease?
So, I mean, you're right with the history in terms of the use of this derivative of the drug, MPTP, I believe it was in 1940s. It was a trial for annual for pain medication, and I guess surprise, medication was discovered by a student in I believe University of Maryland, and he took the drug, and within 3 days he developed symptoms of Parkinsonism, and he died, I believe, 2 years later for something totally unrelated, cocaine overdose or something like this. But that shed light on how things work with Parkinson. And a few years later, 1967, first medication came into life, I would say, which is Sinemet. And company MERS gave the first patent to the medication. So from 1960s until now, we used, we still use Sinemet tremendously in our practice. But we have to be careful. We can't use Sinemet on every single person. We cannot overly use it because it does have a lot of side effects. We have to consider the age, we have to consider the risk factors, and we have to consider how significant the symptoms are, because not every patient with Parkinson has tremor. Majority do, yes, but some have slow movements, some have rigidity. Parkinson is a very complex disorder.
And there's newer treatments now, right?
Yes, there are some medications, we call them dopamine agonists. Those are something that mimics dopamines or keeps the dopamine active or symptoms of dopamine in the brain. That helps a lot, but they also come with significant side effects, mainly sleep attacks. So I always tell my patients, when you're on dopamine agonist, if you're driving long distance, this is not the right medication for you. And also can cause mood swings. And for some reason, it can have patients be pathological gamblers or have other addiction to certain things. So they come with significant side effects. Other medications, inhalation type of medication just came into to the market. In outside United States, they're actually pump of Sinemet that you can use. It has less side effect than the typical Sinemet we take per mouth. That's used outside United States significantly, not much here yet. Hopefully, in the upcoming years, we'll be using it more and more for patients who fail to respond to medication that they take per mouth.
And what about vitamins? I know vitamins are now part of the regimen for Parkinson's disease. Can you tell us about vitamin infusion therapy?
Absolutely. What makes, I guess, as you mentioned earlier, neurologists they always look into one-way street. They don't have two-way streets. For me, managing Parkinson has to be multi-dimensional approach, including medications that we usually use, plus vitamin supplements.
And which vitamin supplements?
So the ones I use as intravenous vitamin infusion, I use something called nicotinamide, which is called NAD+. So that protects the mitochondria in the brain.
And that's a B vitamin, correct?
No, it's a pure nicotinamide.
It's pure nicotinamide. Okay.
Yes, it's called NAD+.
Okay.
I also use taurine. Those an amino acid that also helps the dopaminergic neurons in the brain. Now, remember, you only have 20% left when your symptoms start. So you really have to protect these 20% left. You can use glutathione, which is very powerful antioxidant. Most of the problem at Parkinson is truly free radicals circulating around, causing damage to the neurons, causing the cell death.
And explain to our listeners what free radicals are.
So free radicals are unstable molecules. When they're unstable molecules, just like someone going berserk on the street, just trying to destroy anything around, same thing with the free radicals. They go around and their job is just to destabilize things. And when they go to a cell, they cause something called oxidative stress. And the more oxidative stress, the cell will eventually die. And that's what causes the dopamine neurons in the brain to die.
If you've just joined us, this is Paradox. I'm Dr. Ira Perlstein with my co-host, Dr. Leanne Talton, and we're talking to esteemed neurologist from Stuart, Florida, Dr. Rabih Kashouty, and we're talking about Parkinson's disease. We want you to call in if you have any questions, but right now we're going to cut to a commercial break. We'll be right back.
All right. Welcome back to Paradox. I'm Dr. Leanne Talton. My co-host is Dr. Ira Perlstein. We're here today with Dr. Rabih Kashouty. We're talking about neurology. Before we get back into the meat of today's discussion, I just want to take a moment to get to know our guest better, to get to know our co-host better. I talked to Dr. Ira about having a little segue, talking about personal stuff, and he said, that's a really girly question. So sorry for the audience that I'm about to get personal, but
Oh, that's okay. You can ask me anything, Leanne.
There we go. So, when we were preparing for the show and we decided that we wanted to kind of present a little bit of the personal side of being a doctor and doctoring, I came up with a list of questions for how to get to know Ira better. And one of the things that I thought I would ask him and you, Dr. Kashouty, is how do you think having children influences your doctoring? And on the converse, how do you think being a doctor has affected your parenting?
That is such a tough question. It was different back when I was training because we would be on call days at a time. They don't do that anymore. But being a doctor and raising children several decades ago taught me three things: tolerance, becoming a better listener, and the ability to have more patience. That's PATIENCE, not PATIENTS.
How would you answer that question, Dr. Kashouty?
It's a very complex question. You might think of it as simple, but it's not. I guess organization skills are very important. Since my wife is a physician and we try to keep speaking about medicine at work, but it's very difficult because when we come home, we still talk about patient, well, how would you treat this? I tried this. Do you think that's a good idea? So patients typically get two opinions, and that's I guess it's a plus. But I try to bring my kids in to the office so they can see how things go, even though they're young and they love to come to the office, especially the older one. My younger one still runs around, but my 7-year-old, he loves. I give him papers to shred. I give him things to do, and he feels that he's doing something, and that's very important. to kind of give him there's a sense of responsibility, and there's things to do, and that we don't just sit around and do nothing.
So how do you think having children in the middle of your doctor journey has affected how you handle patients? Do you feel like it's affected you as a physician having children?
Not necessarily, no. I think it just gave me more responsibility to handle. Handling kids is different, obviously, than handling patients. It's two different things that I love to do. But I still give them the time that they need, and that's what I guess keeps me going.
That's one thing my patients love about you. And it's one reason I wanted you as a guest on our show today, because you're not just a good neurologist, you're an excellent listener. And my patients will tell me, when I went to see Dr. Kashouty, he's the first neurologist that actually listened to my symptoms. It seemed like he cared. He wanted to hear my story. And that's a hard skill to develop, but you've done that, and you've done that well.
Thank you for the compliments. That's really nice to hear.
Sure.
So before we went on break, we were talking about Parkinson's disease. We were talking about treatments for Parkinson's, and I have another question for you about new treatments regarding deep brain stimulation. Can you tell us about that?
Yes, that's a very important piece of treatment when it comes for patients with Parkinson. However, it's not meant to be first-line treatment. It's something for advanced tremors that are unresponsive or little responsive to medications that we use, and also can help with patients who have been on medications for many years and develop something called dyskinesias, which means involuntary movements, and those are very bothersome to patients. So the deep brain stimulation, they're inserted in certain areas in the brain, and they stimulate certain electrical discharges in the motor strip in the brain to control some of those involuntary movements. We still don't know too much about it, but it had made significant improvement over the past few years.
And where do you send your patients for deep brain stimulation?
Unfortunately, depends on insurance, and we have to, send people sometimes University of Miami, sometimes locally, or sometimes in West Palm Beach. So it really depends insurance-wise. We don't have much power on that.
Okay. We're going to move on to stroke.
Sure.
Because this treatment for stroke has really changed. Stroke used to be really devastating. And now with the advent of stroke centers, interventional radiology, TPA, tissue plasminogen activator, clot busters, so to speak, the prognosis of stroke, if caught early, can be very promising. What is the difference between what a neurologist might do, a neurosurgeon, or an interventional radiologist during a stroke? Or is it a coordinated effort between everyone at a stroke center? And can you comment on that for us?
Of course, yes. With the advent of MRI, that's where things moved forward significantly. Without MRI, I would assume that there is not much advance when it comes to managing patients with stroke. Strokes basically can affect any part of the body, whether it's your speech, ability to see, ability to move, ability to sense. Now, it could be many different reasons, but if there's a clot, and if they fall with symptom-wise, if they fall within the window, whether it's 3 hours or 4.5 hours, now there's different criteria we use, and we're able to capture that on imaging, and with the help with interventional radiologists or neurologists that are also trained in this, they were able to actually have the clot retrieved to preserve whatever's left behind in the brain.
So like they go in and grab it?
That's one way, or bust it inside, or there's different ways to do it. It depends the location, how big it is, and how far the symptoms have been going.
So if one of our listeners thought they were having a stroke, what are the warning signs that they need to watch out for and make sure that they're immediately transported to a stroke center?
So stroke, you can literally present with anything. You can have sudden onset of weakness, whether it's one side or one arm or one leg, or you can have loss of sensation in the whole body or one side as well. You can lose vision. So there are many, depends really on where that clot or where the stenosis, the tight areas in the blood vessels in the brain causes reduction in blood supply to the brain. So it's really, very diverse. But if you feel as a patient, you have symptoms of weakness, numbness, visual problems, you should not hesitate to go right away to the emergency room. And the doctors in this area are very equipped to manage patients with strokes.
But you shouldn't drive yourself.
No, absolutely not.
Absolutely
I wouldn't.
not.
I don't think
So if you've just joined us, we're here at Paradox. I'm Dr. Ira Perlstein. My co-host is Dr. Leanne Talton, and we're with esteemed neurologist, Dr. Rabih Kashouty. We're talking about stroke. If you have any questions for us, give us a call at 772-220-9788. Dr. Kashouty would love to answer those questions for you. Now, I want to talk to you about a passion of yours and why you got into it. And it's a little controversial, but it's medical marijuana. And I know that I've been to some of your lectures on the use of medical marijuana. How did you get into the interest that you have with medical marijuana, and how has it helped you and your patients as a neurologist?
This is a very interesting topic, and we many times we had spoken about marijuana and medical cannabis in general. That's the best word we can use. Marijuana to me is a natural substance. It's not a recreational drug anymore. Things have been, I guess, there's a taboo when it comes to marijuana from the 60s, 70s with President Nixon, as we previously, mentioned. And or also going back to 1920s and 30s. So this is nothing. Marijuana has been used for thousands of years even. So there are a lot of benefits using marijuana, whether it's for a patient with Parkinson or seizures or patient with ALS, nerve problems, chronic pain. There are many neurological problems that marijuana can help. There's many research out there that proves that. To me, it's a very good medication. That's what I call it. I call it as a medication to use for pain rather than using opiate-derived medication, which have more side effect than anything. I think medical cannabis has the least side effect with the best or the most benefit. And we can try CBD, which is cannabinoid, and that has the non-psychotic effect, plus the THC, tetrahydrocannabinol. But when people smoke, typically marijuana, they only get the THC and they burn the CBD, and that causes the psychosis or the high sensation, as people call it. However, in medical cannabis, we use both. When CBD is combined with THC, CBD blocks that psychosis or the high sensation. CBD, THC together, they work in conjunction together, synergistically to help pain, spasticity, muscle spasms, and seizure reduction. So that's the benefit of having both at the same time.
Do we understand why it helps pain?
Well, endogenously, that means part of our body, we have receptors called CB1 and CB2. And part of those receptors, when you have pain, there are certain molecules that attach to those receptors. And therefore, when you take something that attaches to those receptors, such as CBD, automatically you're going to get relief. You're not taking anything artificial. You're taking something natural. And since we already have receptors, they are ready to activate to be activated by the CBD. We get benefits for pain and many other things, whether it's for seizures by lowering the number of attacks. And some patients have 10, 20 seizures a day. And that's, when you lower it down to one seizure every other day, that's life-changing experience for that patient and the family around the patient. So
how do you decide, as an expert in medical marijuana, the dosage form to give the patient, whether or not they're going to vaporize it, whether or not they're going to use it as a drop under their tongue, whether or not they're going to use it as an oil, and how do you determine the ratio between the CBD and THC?
I was with Dr. Yono, one of the first ones to be approved for medical cannabis when it first got approved here in Florida. And unfortunately, state of Florida gives you, there's a lecture or course that you have to take, but doesn't tell you, it does not direct you as a physician how and what to give. However, we studied many research papers and we read many things online, and with experience that we have managing many patients, we finally we can say that we have a special dosage for certain type of problems. Now, I always give the option to the patient. I tell them, would you prefer vaporized treatments? Would you prefer the tablets? Would you prefer liquid? My preference would be combination of two things, whether it's liquid or tablets plus vaporized treatment. The reason why I do that, vaporized treatment works very fast, doesn't last long. When it comes to tablets or liquid or gummies, it doesn't matter really. It's basically sustaining certain number of in your body. So you need combination of both. So if you have an acute attack of pain, you need the vaporized treatment to help with that. But to treat your chronic pain, your everyday pain, you need something that you sustain and you have to take it every day. So combination of two things will be the best.
So do patients have to be referred to your practice for this, or can they self-refer? I mean, if people, I have a lot of patients that are interested and they just don't know what to do next.
It's a combination of all these things. A combination of all these things you mentioned, Dr. Selton. So I have patients who self-refer themselves, and some of my own patients, I tell them, well, we have option A, B, C, D, and one of those options are medical cannabis. And patients telling other patients as well. So also word of mouth is very important. And also the most important thing is now people are more aware of benefits of medical cannabis. Now they're seeing people using it with literally no side effect, or little side effect. So seeing it, let's say one patient tells me, I've seen my neighbor use it for his pain. I think I want to give it a try, but do you think it's a good idea? So they come in and I discuss with them the benefits, and I tell them, well, this is how we can use it. However, it's expensive. Unfortunately, we still have problems with how much it costs.
Right. And insurance will not cover it because it's not legal nationally and it's only legal state by state. Or how are we going to get insurance plans to get on board with paying for this?
I personally don't see that happening, Dr. Percy. This is, insurance will know that, in my view, they're going to lose money, because if you're going to get insurance for medical cannabis, 99.99% you're going to end up using it. So the insurance will pay out of pocket for that. I mean, from their pockets, obviously. I don't see that happening. Plus the federal versus state, it's an issue.
So we still have some hurdles.
Major hurdles.
Yeah. And to me, one of the biggest hurdles are it becomes part of their medication regimen. And now they're going on vacation, and they're vacationing out of the state, and they're going to a state where it's not legal medically or recreationally. What happens?
It's very. I get those questions a lot, and the legal way to answer that, I tell patients, please do not take it with you, because if you get caught, you're gonna, you might have problems. However, at this point, on the news, we haven't had one issue yet or one case that someone got stopped at the airport because they're carrying their medical cannabis. I don't anticipate that's going to happen, because if that's, if the first case is going to happen, it's going to open a Pandora box. There's no way around it. So I think federally, they know there are a lot of movements between states and states. You can, especially in Florida, people travel from Michigan, New York, New Jersey. There's no way to stop it. Unfortunately, they have to come up with it, with things to fix it. I don't see that happening anytime soon.
Do you ever see a patient who's referred to you for medical marijuana and you say, you're just not a good candidate for this? And what are some of the criteria that you look for that would make them a good candidate versus someone who you might refuse to prescribe medical marijuana for?
It's a good question. I always try to stick to criteria that state of Florida has, for physicians to prescribe medical cannabis. I mean, there are some patients who come in to me and say, "Hey, I want a medical cannabis because I feel that I have nightmares at night, or something that doesn't really, doesn't fit well." So you can easily pick those up very easily and say, "Well, maybe this is not the right way for you to go. You might try behavioral therapy or any other therapy, or you might try a different route of, things." So we try to stick to those criteria, and most of the time, patients are actually, they come in, they're really looking for help.
And, speaking about from the patient perspective, I think that because a lot of these patients have lived through an era where this was stigmatized, that they are still worried about appearing like a drug user if they have questions about this. What do you think patients feel when they come into your office? Do you think they're worried about that? And what do you do? What does your office do to try to alleviate those fears of being judged?
There, unfortunately, in this area and any other areas in Florida, there's still some physicians who actually tell their patients, "You cannot use medical cannabis because we don't believe in it, and if you use it, we're going to discharge you." And I've seen many of my patients going through that. So they fear when they come to me and say, "Well, Dr. X said if I go on medical cannabis, am I going to lose that doctor? Or I feel, I might, be stigmatized that I'm using medical cannabis." But telling them about, the experience of other patients, I think helps them significantly. And coming from a neurologist perspective and say, "Look, we've seen this, we've been through it, we've been doing it for past 2-3 years now. These are the benefits, and this is how it's going to help you if you take it." I think patients will eventually feel more relieved and, I guess, happier in a way to try it if they really reach a point that they're not getting any help with anything else they try.
And patients with good experience is what's going to change the stigma.
Exactly. Yes.
Now, obviously the changes in regulations and laws has potentially opened up a whole new world for research, I'm hoping, in medical cannabis. What's new on the horizon?
There are a lot of research out there when it comes to cannabis. Now, if you go back to 1970s and 60s, President Nixon, unfortunately, had gathered significant amount of research papers that are only negative when it comes to cannabis. And that's how he said marijuana in general is not something we can use. And he labeled it next to cocaine and heroin as some substance that we should not use. He totally neglected the positive effect of marijuana. But every year, there are thousands of papers being published about the positive effect of marijuana. And there's no hiding anymore behind it. The substance or the medicine helps in the end.
Where do you think we're going to be 2 years from now?
2 years, I don't think things will change. 5 to 10 years down the road, I think federally, the discussion will start to happen to make it legal throughout the United States.
So making it legal is one big hurdle. And then you say the second maybe another hurdle is changing the stigma, and then also making it affordable is what your final hope would be.
Yeah,
so what can patients expect when you prescribe them medical marijuana and they get a card from the state and they can go to a dispensary and buy it with the recommendations that you've given them? What can the average person expect to pay at a dispensary?
It ranges literally from $100 to $400 a month. And that's a lot. I mean,
that's a lot of money.
Some patients cannot afford it. And a lot of my patients qualify to get it, but cannot afford it. So that's an issue too.
So we've come a long way from the 1938-39 movie Reefer
Yeah.
Madness, but we're
Yes.
not quite there yet.
No, not yet. Soon, hopefully, well, things will change, but things are moving very slowly, unfortunately.
So you say your office does take self-referrals. So if a patient listening feels like they're not sure if they're a good candidate, is there any online resources that they could go to learn from an educated perspective whether or not they are a good fit?
There are many things online you can go to. For example, on my website, premierneurologycenter.com, I have a section that I had written myself about the benefits of cannabis, who qualifies, typical dose that I prescribe. So there are many resources there patients can use.
Great. So listeners who are liking what Dr. Rabih Kashouty has to say should go to his website,
Neurologycenter.com.
Give us your phone number.
My cell phone or my?
No.
Give
Your
every
office,
listener
your
your
office
cell
phone number
phone.
for our listeners.
Of course. 772-210-2447.
This has been great. You are so kind to have joined us. High anxiety guys with the hurricane. Be careful. Do your diligence. Get your shutters up. Remember the water tips that I gave you. We're going to end with high anxiety. There's a song, High Anxiety, and I think that we might be there a little bit this weekend. Frank, can you key up High Anxiety for us?
High anxiety.
There we go. Thank you, everyone. We look forward to seeing you all next week
Thank you for having me.
on another episode of Paradox.
Anxiety. It's you that I fear. My heart's afraid to fly. It's crashed before. But then you take my hand